Okay, live on Facebook now too, Roland.
Right, lovely. Just let people join. Okay. As people pour in through the waiting room. Right, lovely. So good morning, everyone. Welcome to the 827. 4 topics we're going to cover this morning. The first is Ewan, you're going to talk us through where we are from an operational perspective. Then James, you're going to give us an update on where we are with the EPIC upgrade. Karin, really looking forward to hearing about where we are in terms of the COVID secure environment status of the hospital. And then Charles, welcome, lovely to see you. You're going to talk to us about the Purple Network and the Disability Champions. So those are the 4 topics. Ewan, over to you in terms of where we are operationally.
I thought actually I'd start with where we are on COVID, because obviously that's you know, in the news a lot at the moment. So over the last month or two, we've actually seen within the hospital a relatively flat number of cases. You know, we may have been admitting more people, but in this wave of COVID, the length of stays have been shorter. So we've broadly been running at around about 30 patients in the hospital, and on average, about 20 of those have been in general beds, and about 10 on critical care. We've definitely seen cases popping up in more unusual places compared to previous waves. So, you know, for example, you know, more patients on the delivery unit, more paediatric cases than previously, but broadly it's been flat. Now, in the last few days, we have seen a bit of an uptake in numbers, but that isn't being driven by what's happening in the community, although there's obviously lots happening in the community. We have had an outbreak on one of our wards, which has led to a number of cases. So we've gone from about 30 into the sort of high 30s at the moment. But just to, as I say, the underlying position is broadly stable, and we know that the sort of community prevalence is largely being driven by cases in school children that are then leaking out into older populations. So we sort of watch what's happening in the community with great interest, and there's clearly a great deal of uncertainty about what will happen with COVID over the next few months. But you know, I say up until now, over the last couple of months, things have been pretty stable. I think, you know, the message from me would be to continue to be cautious, and to continue to take all the usual precautions on the ward to avoid catching from patients or passing on to patients. That's where I think we are broadly on COVID. There's obviously a little bit of worry about what will happen with COVID, with flu and RSV and a variety of other viruses over winter as well. We've got plans to be able to test for those in the coming weeks. The second thing I thought probably ought to talk about is a blend of where we are today and what we're sort of planning for over the next 2, 3, 4 months with winter. So I think it's probably fair to say we've had a very, very difficult weekend in the emergency department, with a combination of really high demand, and whenever we go through a period of several days of discharging fewer patients than we admit, we get into trouble. And I think probably Sunday, Monday, and today have been some of the most difficult days we've had in the emergency department. Certainly, well, almost certainly ever. And I think, we know that it's likely over the coming months that we'll continue to see high emergency demand. That's there's never been a winter when that hasn't been the case. So what do we need to do about that? Well, I guess we can sort of lump that up into three buckets: to pre-hospital, in-hospital, and post-hospital. And the pre-hospital things, we're working with all of our partners in the system, with primary care, with community services, with the ambulance service, to look at ways of reducing the number of patients coming to the hospital, and particularly patients who are accessing services here unnecessarily because they actually need different services. The second is the sort of the in-hospital stuff, and I think there's a range of things we can do. We've talked a lot over the years about flow. So one of the big problems we face is not just the mismatch between the number of beds we have and the number of patients, it's the timing of those. So one of the things we regularly ask is for people to work on early discharges. So we've been looking at the discharge lounge utilisation over the last few weeks, and looking at the wards who use the discharge lounge first in the morning, looking at the first 3 patients going there each week. And last week, the sort of 2 standout wards were C6, who had 6 of those 21 patients, including the earliest, and SAU, who had 3 of those. So there's probably nothing particularly extraordinary about those wards other than the processes that they're using to get people to the discharge lounge and free up beds early in the morning. So just ask people to really focus on that if they can. And then the other thing that we're hoping to hear about this week, and if not early next week, is around winter funding. There's a whole range of schemes that we put in for services at the variety of front doors and within the hospital to speed up discharge and aid with processing emergency patients. We're pretty hopeful that we'll get quite a lot of that. The final thing, obviously, is post-hospital. So we're continuing to work really hard with our partners in the community services and local authority to make sure that people, particularly elderly, frail patients, don't get stuck in the hospital once they're ready to go. And if we were to rewind before the pandemic, we probably had 10% of our beds filled with what were previously called delayed transfers of care, but essentially old, frail patients who require some form of ongoing care before they can be discharged. And the great work that's been done in the system over the last 18 months means that's currently running at about 4%. There's still more to be done, and obviously, worry about what will happen with staffing over winter, particularly with COVID. But that's clearly a really important plank. And then I think finally, there's no point pretending that this winter is going to be anything other than very difficult. If you look at social media, you'll see similar things happening up and down the country in hospitals, and it's going to be really tough, but really, really important that we all pull together to address that challenge. And Roland, we've got this time next year, we've got a lot of additional capacity and a lot more staffing coming. So there is an end to this particularly acute problem that's not too far away. We just need to work through the next 6-9 months.
Lovely, Ewan. Thank you very much. Is there anything else you want to cover?
Well, I guess the only other thing to say is that a thank you to all the staff who are really struggling this week. I mean, whilst not large numbers of staff have got COVID, many of them, their children have got COVID and they're off work at the moment, self-isolating. That is putting a lot of pressure on the organisation. So just a big thank you to everyone who is at work at the moment, working under really difficult circumstances.
Okay, lovely, Ewan. So thank you so much. A couple of questions from me quickly, if that's okay. So a lot of colleagues will be seeing in the media what's going to happen with COVID. Are there going to be additional restrictions, vaccine take up, and all that sort of thing? What I heard you say is, well, you didn't quite say it like this, but if we were to go back to December last year and into early January, before the vaccine program had really been rolled out, we knew from the numbers in the community what was going to happen to the hospital, didn't we, broadly? Which was going to be a kind of rerun of what we saw in wave 1 in sort of March, April period of last year.
Yeah.
And I remember, we were obviously looking at the model developed by the university and the Addenbrooke's or CUH infectious diseases team, and it was pretty clear that we were going to see a very significant increase. What you're saying is now the model is much more uncertain. We're creeping up, but we're not seeing that exponential rise. But we've got all the plans in place for if we do see a continued increase, not anticipated to be exponential, we have the, if you like, the capacity plan that we had in place for last year ready to go.
Yeah, so I think amongst all the uncertainty, the one thing that is certain is it's the chance that it will be like last January is infinitesimally small. I can't see that happening. We know that vaccines make a massive difference. If we didn't have vaccination with the current community prevalence, we would be being overwhelmed by COVID at the moment. So vaccination is clearly the most important thing. So if you haven't yet had your booster, I mean, do get it. There's really good evidence that it protects. The range of possibilities currently on the modelling is pretty wide. So yeah, so we didn't know quite how big the wave was going to be last January, but we knew there was one coming. It's really difficult to predict what will happen. I mean, clearly we will be able to cope with whatever that throws at us. Clearly, if it's a large wave, that will put significant pressure on other services, but we will deal with whatever comes our way.
So then in terms of COVID, then, so if we're all thinking about what we can do, we've got a capacity plan, a staffing plan. We know that works, broadly speaking. We're not anticipating this exponential rise back to where we were at the beginning of this year. So the one thing we've all got to do, or the two things we've all got to do to help then are get our flu vaccine, get our COVID booster, number one, and then number two, and we'll hear about this in a moment, Karin, is maintain all the vigilance we're seeing around the hospital at the moment in terms of mask wearing and distancing and following the guidelines very clearly. Okay.
Absolutely.
Okay. And then just secondly, then Ewan, so, and really helpful, some sort of myth busting there in terms of the operational position. So the hospital is not full of frail older patients who should be elsewhere. You're saying we were at 12%, 9%, we're now at about 4%. People would dispute some of those numbers, but our system partners have worked really well alongside us. Yes, there's more to do, but that's just helpful for us to understand, isn't it? Yeah.
So, and I mean, the other figure that tells me that things are different is before the pandemic, we would be discharging something like 15 to 20 complex discharges a day, and we've been running for a lot of the pandemic over 30. It's now running in the sort of high 20s, low 30s on a pretty consistent basis. So that tells me that something has changed. It's not to say that there aren't patients who are still some patients who are don't still need to be here and are still waiting for things, but the numbers are very, very much smaller than they were.
Yeah. And then there's pressure, obviously, we know, on general practice outside of the hospital on your first of your 3 blocks. But the second piece, again, if we're coming back to what can we do, you're saying, look, the maths, the numbers tell us there's a huge amount that we can do in the hospital. And you and I, with Ashley, Lorraine and Sue, met with all of the specialty leads, didn't we, 10 days ago? And we're going to meet, I think, all of the specialty leads, heads of nursing, matrons, divisional directors and operational managers, aren't we? Is it Monday or Wednesday next week? I can't remember which day.
It's next week. I think it's Monday, but I can't remember the exact date.
Yeah. And what we're going to do there is we're going to share the feedback that we've had from all of the specialties, which range from the cancellation of some cancer surgery through to the immense pressure that the emergency department are facing, plus the pressure faced on the wards. And it's to try and get to a collective understanding. And then, what the maths is telling us, Ewan, is actually there are some things we could do right now in the hospital that would alleviate a lot of that pressure. And we need to focus on the right things.
Yeah, and it's not to say that requires enormous amounts of things to be done. I think actually relatively small improvements at a ward level, magnified across 40 wards, becomes a huge difference. And that's not to in any way belittle how difficult that is at the moment when staffing is so tough, because it really is at the moment. But it's relatively small changes, managing to discharge a patient a few hours earlier, that will make collectively a huge difference.
Yeah. Okay, good. Well, Ewan, thank you very much then. So what we've got to do then is you're saying 3 things to us. You're saying, number 1, get vaccinated, flu and COVID. Number 2, maintain social distancing and vigilance. And then number 3, everybody leaning into this journey we've been on for the last 2 weeks, building on lots of comments before that. But then the meeting we're going to have next week about how are we going to get to a collective picture and collective endeavour in the pressure that we're under.
Okay. Yes, absolutely.
Good. So Ewan, thank you so much on that. Really, really helpful and very clear update. James, could we come to you on where we are with EPIC, a different topic?
Yeah, thanks, Roland, and morning, everyone. So I came to this meeting a couple of weeks ago to brief everyone about the EPIC upgrade programme, and I promised I'd come back and give you another update. And also, just over the next 2 to 3 minutes, I just want to focus on a few kind of key actions that teams should be aware of relating to the downtime and how we can be best prepared to make sure that we're all ready for the new version of EPIC. So just to recap, the upgrade will happen on the night of the 6th, 7th of November. That's a weekend. Specifically, the downtime's now being confirmed as taking place between 1 a.m. and 5 a.m. on the Sunday morning. So that's the normal window for downtimes whenever we make a change to Epic. The difference will be that this is slightly longer at 4 hours than the normal 1 to 2. A few points about the downtime. A read-only version of Epic will be available throughout, but you won't be able to document. So you'll still have access to patient notes, labs, demographics, and so on. But the expectation will be that teams will need to document the information overnight and then input it into Epic as soon as the new version is live around 5 a.m. And the type of activity that I mean is, ED admissions, patient transfers, medication administrations, any OBS or ordering and charting. And then once the upgrade is complete, the new version will be available across the site and to any off-site locations or satellite units to also use our Epic system, so everyone should be able to see it and use it as usual. Key actions required this week. So a new BCA printing icon is currently being pushed out to all our computers and will be available tomorrow. So from tomorrow, could I ask that teams check that you have the icon on your BCA computers and that when you double click it, it does work. If it doesn't, please call the IT service desk on 257 257 and they will help you to sort it out. Please also ensure that you've got enough paper and ink in your BCA printers, just in case we need to switch to full BCA during the upgrade or downtime. And I should say that that's really unlikely to happen, but it's important that it's there as a backup. And then lastly, we have drafted a full operational plan for the upgrade, which sets out all the key actions that I've just talked about, both prior to and after the upgrade. And that's been developed with the operational readiness group. And so it's been circulated to divisions, but it'll also be released in tomorrow's bulletin. So could I just ask if you have 2 minutes to have a look at that document and familiarise yourself with the actions, just so you know what to do if you are working over the 6th or 7th of November. And that's all I wanted to say, Roland, but I'm happy to take any questions.
Great, thanks very much, James. So you and the team could be approaching this with whatever, we're going to switch it all off on overnight, Saturday, Sunday night, and see what happens. I'm sure it'll be okay. There's not that many people here then. It's quiet. A few people will get grumbly, but we'll be okay. It'll all start up again on the Sunday morning. Does that make your life easier?
Well, I suppose from a technological point of view, eHospital has done a huge amount to make sure in terms of checks and assurances that everything will work. And then operationally, we've been having a discussion, with all the teams in terms of familiarising themselves with what they need to familiarise themselves with, the new version. So confidence levels at the moment are sort of, fairly high for the upgrade in terms of everything working and everyone being comfortable with the changes. But no, we're not resting on our laurels until it's done.
No, I mean, thanks, James. So I think the point for all of us, again, watching the 827 and reading the bulletin, is you and the team have put in a staggering amount of work to make this as seamless as possible, including all of the backup plans in the event that something that you haven't planned for goes wrong, which might happen. We should respect and honour that effort that you've all put in as a team. And you're saying, this is when the downtime is happening, this is how you should be prepared for it. Here's the business continuity plan, and here's the document I'd like you all to read. And if we do our bit,
summary,
then all the work that you've done, we're setting ourselves up for the best possible position for our patients and staff.
Absolutely.
Great. Well, James, I think a huge thank you to you and the team. And we're very glad that you haven't just sort of swanned around on the sofa, hoping it'll all be okay. So thank you. Thanks. Good. And we look forward to hearing how smoothly it all goes over the weekend, which I'm sure it will. So thank you, James. Okay. Good. Karin, could we come to you on COVID Secure?
Thank you very much, Roland, and good morning, everybody. Yeah, so on the 30th of September, we provided an update in terms of guidance in the bulletin, and since then people have been asking for some further clarity around organising events. So we all recognise that staff need to socialise, but I think the key thing is we're asking people to do that in the safest possible way for themselves and for our patients. And it links to what Ewan has said earlier in terms of the staffing levels we have. You know, we're going into winter. So we're really concerned about, you know, the potential impact if significant numbers of staff have to be absent from work over the coming months, and the impact that low staffing will have on the staff that are here, on their morale, and also their work-life balance. So it goes without saying that any event that's organised, staff Christmas party, you know, staff who are symptomatic or have a family member who has tested positive or self-isolating should not attend any social event. So it's really important that the person who's planning the event takes all reasonable measures to reduce the risk of the COVID-19 transmission, and then the impact on services should staff required to self-isolate. So we've previously mentioned we've given three principles for staff to make decisions, and those three principles remain. So firstly, seek to minimise the risk of entire groups of staff having to self-isolate and then impact on the team's ability to deliver the service. And what this means is please try and avoid whole specialties and services attending the same party. I know that if all of the electricians in the hospital were to be at the same party and they all had to self-isolate, we will have a problem. So really for all of the events is really carefully consider that. The second is to consider and plan the actual event in a way that minimises the risk of catching or transmitting COVID-19. So what this means is plan, to try and hold the event outdoors or in really well ventilated areas. Make sure that the venue is appropriately sized for the number of attendees, and use COVID secure measures such as hand washing and mask wearing where possible. And also consider a shorter duration. The shorter the event, the better. And really importantly, asking all attendees to take a lateral flow test on the day of the event. And then finally, the last principle is really consider what it would mean for our patients and others in the event of a whole specialty not being able to come to work. So especially in critical specialties, please make a plan for what you would do in the event that there was a transmission, and to plan with named individuals who could staff the rotas in the coming days. Also taking into account that we're going into the Christmas period and people will be having booked annual leave as well. So these are the three principles and real practical things for people to do, and really carefully consider, taking active steps to make sure that event is as safe as possible. It will go out in a bulletin today, but those three principles remain, and it's really for those people organising the events to really ask themselves, have we taken all the reasonable measures to prevent groups of staff having to be off?
Lovely, Karen, thank you. Very, very clear. So we're not sort of preachy and patronising about this, are we, at all? But we're asking people to use the same judgment that they've applied so well over the last 18 to 24 months in this case. And it's just like, at some level, it's like driving a car, isn't it? I mean, we don't either not drive or drive at 100 miles an hour recklessly. We get to some middle ground, don't we? And we've all got a certain number of units of risk that we can use up in relation to COVID. And what we're saying is use those carefully. And those three principles are saying, yes, people can meet up, but do it in a way that's sensitive, I think.
Yeah, absolutely. This is about giving people as best possible guidance in order for them to make decisions. We make decisions, as you say, every single day, which events we attend, when we go to a shop, if we go to a shop, and the same applies. And really, it's only the people locally that really understand the impact of their services and what measures they can have in place should the worst happen. And it's really thinking about those people who are left behind and the impact on our patients in a very difficult time.
Yeah. Yes, and all the feedback we've had from people who've come together in groups without thinking this through and have then either become infected with COVID-19 or had to self-isolate has been, gosh, was it really worth getting together in that way? Others where they have become infected or have had to self-isolate, where they've gone through a process, feel, yeah, well, I did what I could and it was reasonable. So that's what we're really saying to people is use your judgment against those 3 principles you've set out, Karen.
Yeah.
Okay. Lovely, Karen. Thank you very much. So we'll take that forward, and that sits alongside all of the work we're doing to protect staff through vaccination, and a lot of the work, Karen, that you've been leading around creating additional space for staff to be able to have breaks in the hospital. Okay, thank you. Good, thank you. Charles, could we come to you to talk to us about the Purple Network and Disability Champions? Welcome.
Good morning, Roland. How are you doing?
I'm doing very well, thank you.
Would you like me to introduce myself and about
Yes.
the Purple Network? Yes.
Yes,
no problem. So my name is Charles Greensit, and in about 2013, I was at a job and I ended up suffering from vertigo, which meant that I lost the high pitch hearing in my ears, both ears, and it never came back. So I can hear people speak, but if you look underneath the headset, you will see that I'm wearing hearing aids. Probably can't see that properly. After that, I ended up obviously out of work and then came back, redid teacher training, and decided still I wanted to be in engineering, so came back to Adam Brooks. And when I was in Adam Brooks, I then, 2019, I ended up in a strange place in Adam Brooks, didn't come to work. Instead, I took an ambulance into work and ended up in EAU4 that ended up with, they diagnosed me with diabetes as well. And they couldn't work out why I was this way, only to find out that eventually after genetic testing, I had something called MIDD, which is mitochondrial or maternally induced diabetes and deafness. And the two were linked, and the hearing damage and the diabetes don't come because, hey, it's going to happen to you. It happens because you've got almost an Achilles heel, and in certain conditions, certain things, you are vulnerable to those two things. And unfortunately, whereas other people in my family have got the same gene, they haven't been hit by anything. I've managed to be hit by both. And as a result, during COVID at the start, they said, well, you need to work from home. That's fine. And at the time, they set up the Purple Network as well. And I ended up quite curious about what this was, because I read about it being about people with a disability and being part of Toastmasters International as well. I've given speeches on the problems I've had with hearing aids, the stigma I've had, how the social interaction is very different with people. And what I have now found is that over time, I've found that actually talking about that, confronting those issues, has made a big difference in life. And what I found is basically stand up, but there was nothing in Adam Brooks at the time that I knew of where I could present myself as an example to help others. And then when the Purple Network came, I joined up a bit later on. And then they said, well, there's going to be these champions as well. Someone to actually step forward and present themselves. What is the condition you've got? So my disability champion for the Purple Network is for people with hearing damage and to help them. And in the same way with the diabetes as well, what needs to be done to help individuals to actually get what they need. For instance, when I did teacher training, I went to the Disability Resource Centre and was told, if you get a dictaphone, if you're not following a meeting, you need to lip read. And they saw I was a lip reader, but I said, well, I'm not a lip reader. And they said, no, subconsciously, you're a lip reader. You haven't been trained in it. You've trained yourself in this skill, But if you get lost in a meeting, you're not going to keep up. You're trying to take notes, draw pictures, because I'm an engineer. You're trying to take down everything and process it. And through hearing aids, you're much slower on processing those sounds sometimes. And then you say, well, what are these little features that I need to help me? And that, through the Purple Network and through presenting as a disability champion, means that I can help others. And I found that a really good way of putting forward that. And because it's a group of people, not just with my condition, but both visible and invisible, whether it's neurodiverse, mental health, so anxiety, depression, it all comes together that we have this network of people who can quite literally help each other. And I think one of the important things for me was when I also did training called the Mental Health First Aid, which is through the Mental Health First Aid England. And that really helped me put together my own mind as well. So fighting my own anxiety and depression and actually helping others as well.
So Charles, thank you very much for being so open and honest, and it's very humbling hearing you talk. Can I ask you a couple of questions, Charles? Is that okay?
Yeah, not a problem at all.
That's great. So just very honestly, how have you found the 827 this morning? Listening to me, Ewan, James and Karin, and they won't be offended. It's just, how's the meeting been for you?
I find it a nice meeting. I found people haven't been pushed in a too directorate professional way. I wasn't sure, I have seen these before, but I wasn't sure whether it was going to be very flat directorate or whether it was going to be nice and open and more of a chat. And it's more of a chat, which means it's very easy for both myself and I'm sure people on Facebook and Zoom to understand.
Okay. So this has been a meeting that you felt able to listen to and follow in terms of the damage to your hearing that you talked about.
Yes. Yeah.
Okay. But there'll be some colleagues for whom that would be much harder, wouldn't it? I imagine. Who you'd be helping as a champion.
Yeah, definitely.
Yeah. Okay. So we need to take away and think quite hard, don't we, about how we're enabling everybody to understand, hear, contribute to what's going on in the organisation.
Yeah. So, for instance, this morning, everyone who's been speaking has basically not had a face mask on, which means for those who need to lip read as well as hear, that means that they can understand through that visual communication, which is important, whether it's on a Zoom call or important in person. It gives those people that communication. And also people have been sitting here not with their hand over the mouth, so I can tell you now that you, Roland, Ewan, James, Karin and Tony, well, except for Tony's wearing a mask at the minute, but isn't speaking, that is an important thing for people to follow.
Okay. So we need to be thinking quite hard, don't we, all the time, Charles? We're talking here about people who've suffered damage to their hearing, but the champions and the Purple Network are looking after people or supporting people who are wrestling with all sorts of challenges. So we need to be quite broad in our thinking, don't we? To make sure that we're able to be as open as possible.
Yes, because people are their own expert in their disability.
Yeah.
But they are often in a case where, in terms of their job, they need to be honest about what their disability is to maximize their own potential, but also to know where their limits are to not make themselves more ill than they already are. So, for instance, as someone with diabetes as well, I know that sitting in this chair all day will push my sugar level up and can have consequences on me. therefore getting up and, believe it or not, moving my arms and my legs is actually very important. And although some people don't recognize diabetes as a disability, it is constituted as a disability still.
Yeah. Really helpful and grounding, Charles. And that point around, I need to get up and move around, not because I'm feeling a bit uncomfortable, but because this is how I stay well, is important. And Charles, can I ask you another question? So you're an engineer. What sort of work do you do?
So I do various things. So I'm trained as a machinist, so I can make various different parts for people. I do quality control, so I can measure parts, tell you whether things are fit to be in the truss or not. Obviously, I do. There are various products in the hospital that come through clinical engineering innovation, and those will often be checked by me. Some of those have been made by me. There's a whole scope of things that I can do, so it's very much a making and doing that I can do, but also translating your idea into a real thing, whether it's a working prototype. I used to actually be one of what's called a model engineer, and I still am. And you used to be able to find me at Audley Miniature Railway for the model engineers. I used to be running both the electric trains and some of the little steam trains from some of my friends in there. And at the moment, I'm actually building what's called a 7¼ inch gauge steam engine. So it will have a little coal boiler on it eventually, and it will be powered by its own little cylinder that will run.
Well, Charles, I mean, the 827 could easily become the 1027, 1127 if we start talking about O gauge and double O gauge model railways and the power of traction engines. As somebody from Lancashire, I'm quite fond of traction engines, and you're building a miniature version of those. But Charles, really terrific to hear about the work that you're doing. Is it ever frightening for you? So my father was an engineer. He's retired now, and the precision required means you need to be able to hear and assimilate a lot of detailed information. And do you ever get to the end of a meeting or an engagement and think, gosh, I need to go back and find out because people didn't appreciate how to engage with me to enable me to be able to do the best job I can. Do you see what I mean? It sounds quite frightening to me.
Yes, that is quite a lot of hard work sometimes to, what I'm going to call, pull out of other people's heads, but also to get them to understand what I'm talking about, because sometimes there is a language that I have, and actually being able to translate other people's language in engineering into that can be very hard. And I did find very much when I was working as a teacher with 11 to 16-year-olds, that gave me very much a skill in itself, because I was working with both high flyers, but also children who did have their own disability, in how to communicate with all those different levels.
Yeah.
And I don't think when I finished university, that if I hadn't have done that as well, I wouldn't know what people are talking about, or they would know what I was talking about.
Yeah. Ewan, do you want to ask a question?
Yeah, no, just a quick question, Charles. I mean, if members of staff wanted to make contact with a disability champion or wanted to get involved in the Purple Network, how would they go about that?
So there are links on Connect2 and the webpage that relate to both the Purple Network and the Disability Champions. There are now profiles that are being put on the Trust website that relate to the different staff with the different disabilities. In terms of the mental health first aiders, this is still something that we are trying to push more in the trust. So some departments are now beginning to engage with it, and others still need a bit of a push. But for any department who has actually got a mental health first aider, and if you know who they are, please make sure that your department, whether it's clinical engineering or whether it's the nursing staff, the midwife staff, make sure people are signposted to at least who the mental health first aider is, even if they can't get to the champion, because they will be able to get in touch with that network and put you in touch with the champion who maybe has a specialist subject in that information. We're not counsellors, but we are there to point people in the right direction.
Yeah.
And I think that's an important point to make and clarify. While we're here to listen, we're here to help people in the correct way, but we are not trained counsellors to that level, just so that people know.
Thanks, Charles.
Good. Well, Charles, thank you very much. A very, as I say, grounding and humbling story to hear about your journey and how you live and work. And also a huge thank you and well done for all you're doing to support other colleagues across the hospital. And I think what we've heard today from you and James and Karen are other examples where we're working to support colleagues, both for our colleagues, but also for the patients we serve and the population we serve. And Charles, thank you very much for pointing us to connect to where our the Purple Network and the Disability Champions can be found. And Charles, I think all the very best as you carry on doing the great work that you're doing, and look forward to hearing more about the model railway in due course. So thank you. So we should probably draw to a close now, Tony. A big thank you to everyone. Just a couple of additional pieces to remind people of. So the staff survey, please do complete it. It's an absolutely central part of how we shape the organisation for the future. Again, please do take up the flu vaccine and the COVID booster vaccinations as soon as you possibly can. We heard about that from both you and from Karen. And then thirdly, Monica, thanks very much for reminding us it's Black History Month, and there are some terrific events on the schedule, aren't there, Monica? And so I do hope people will be attending those as part of our much broader engagement with all of our staff across the organisation. So big thank you, Charles, Ewan, James and Karen, and Tony, obviously, and everyone for joining. See you all very soon, and have a great week. Thank you and bye-bye.